We'll get on to the penultimate 5-minute slam sessions. We have Iman Farhat, a PhD student in epidemiology from Quebec, Canada, presenting on trends in hepatitis C care for people who inject drugs in Quebec, Canada, provider specialty and patient characteristics.
Thank you for the introduction. I'm really honored to be here today to share my work, part of my thesis with you, which is on trends in hepatitis C management by provider specialty among people who inject drugs. I have no conflict of interest to declare. People who inject drugs carry a disproportionate burden of hepatitis C in Canada. As of 2019, nearly half of people who inject drugs had ever been infected with hepatitis C, and 1 in 4 were living with chronic hepatitis C. Historically, treatment was challenging. Interferon-based treatments had low cure rates, severe side effects, and required specialist-led care with frequent monitoring. That changed in 2014 with the arrival of second-generation DAA, which are highly effective, shorter, better tolerated, and required less intensive monitoring. This shift made community-based, primary care-led model possible, integrating hepatitis C treatment with harm reduction and prevention services. Most importantly, it allowed people to receive treatment closer to home. So this shift given this shift, we wanted to know who has actually been treating people who inject drugs when they're infected with hepatitis C in Quebec over time. Our objective was to describe trends in hepatitis C management by provider specialty among people who inject drugs in Quebec from 1990 to 2018. We conducted a retrospective cohort study of all reported hepatitis C cases in Quebec from 1990 to 2018 using the mandatory reportable disease data set. Cases were linked to healthcare administrative data, physician billing, and immigration records to obtain health utilization and demographic information. Using a validated algorithm, we identified people who inject drugs, and then we modeled the monthly rate of hepatitis-related visits using a generalized additive model with a negative binomial distribution and splines. Patients were followed from diagnosis up to 18 months, and we stratified the analysis by provider specialty. Among people who inject drugs, the monthly rate of hepatitis-related visits varied by specialty. Over time, gastroenterologists and family physicians accounted for the majority of visits. Gastroenterologist visits stayed relatively stable over time. In contrast, family physician visits increased steadily post-2010 and decreased after 2014. Overall, family physician had 21% higher rates compared to gastroenterologists. In conclusion, most hepatitis C care for people who inject drugs occurs in primary care settings and in gastroenterology clinics. Leveraging primary care as a key entry point is crucial to reach people earlier, treat more patients, and close the gap in hepatitis C care cascade. And I'd like to thank my co-authors and supervisors, as well as the CHR for funding me. And you can email me if you have questions.
Can I just ask, primary care physicians, we have specialist inclusion primary care physicians that have an interest in people who use drugs, the homeless, etc. The vast majority of our primary care physicians want nothing to do with those populations. So did you look, were these specialist primary care physicians or were these just general GPs?
So we don't have that information. It's not as granular. We know that they're family physicians. But I think what we're observing is in rural areas, there aren't that many primary care physicians who are specialized for people who inject drugs. But in urban settings, most people who inject drugs, unless they are severe cases of co-infection, they can be treated in a clinic that is targeted to people who inject drugs.
Thank you so much.
Thank you.
Well done. Thank you.